Great. Hello, everyone. Welcome to our meeting. So Wayne couldn't be here because of some meeting. I think he may arrive later. So I started the meeting, and we are going to have John to present us his work. Let's go quickly around the table. We may have some new people in our list too. Let's just go quickly around the table, and then John can present. Who wants to go first? I can go first. I'm Navid Gaffarzadegan. I'm a faculty member in Department of Industrial and Systems Engineering at Virginia Tech. Gary?
Gary Hirsch. I'm an independent system dynamics consultant, primarily in healthcare.
Great. Erin?
Sorry. My name is Erin Stringfellow. I'm an instructor on the research or investigation track at Harvard Medical School. And my background is really in drug use and addiction, but I participate in a lot of modeling studies.
Great. And you recently got an appointment in Harvard, right? Am I correct?
Yes. Yeah, in the last few months. Yeah.
Great. Congratulations.
Congrats.
Thank you.
Deb?
Hi, I'm Deb Polk. I'm a psychologist at the University of Pittsburgh School of Dental Medicine.
Great. Larissa?
Hi, I'm Larissa Clancy. I'm a research assistant professor at the Friedman School of Nutrition Science and Policy at Tufts University. And I'm working with Dr. Jalali on a career development award. So I'm trying to learn system dynamics and apply it to a nutrition related research question.
Wonderful. Fatima?
Hello, everyone. I'm Fatima. I'm a second year PhD student in Industrial and Systems Engineering at Virginia Tech. And my research is using system dynamics and machine learning in healthcare, which is why I'm here.
Great to have you, Fatima. Adina? Adina Tahir. Okay. I think we have also one more, Nazli Gül.
Yes, hi everyone. My name is Nazli. I'm a master's student at Boğaziçi University. My research topic is related to disease modeling. So I'm interested in this meetings, and this is my first time. So I'm glad to be here. Thank you.
Great to have you, Nazli. So did I go through all the names, because names are moving around? Yes. Anyone? So if everybody has introduced themselves, John, floor is yours. You can just give a quick introduction and then start presenting.
Thank you. Hi, everyone. My name is John Ansah, and I'm an assistant professor at Case Western Reserve University and at the Center for Community Health Integration. And I used to work in Singapore for 11.5 years before moving here just last year, early this year. So this is work that we did in Singapore. So I'm going to talk to you about that, and hopefully you have a lot of questions. I have a very long slide. So what I'm going to do is I'm going to try and go through and then make sure that I leave enough time for questions. So this is a project about Singapore, and those of you who don't know Singapore, this is just a quick introduction to Singapore. Singapore has about 5.6 million individuals in a 707.1 square kilometers. So you can just imagine how congested the place is. But it's a wonderful place, and it has 3 main ethnic groups: Chinese, Malays, and Indians. And then everybody around the world is there in Singapore because the foreign population is quite significant. And these are some of the basic characteristics or basically about the healthcare system in Singapore. If we look at Singapore as a country, Singapore is aging quickly. And if you look at the graphs on your left, you see that those by 2050, we are expecting about 36% of the population to be 65 plus. And then by 2050 again, those who are going to be 80 plus will be around 14.2. And that gives you a clear idea about how quick the country is aging. And if you look at the individuals by the multiple chronic conditions, if you look at the male, female, the more people get older, you can see that they are accumulating chronic conditions. So you can see the number of proportion of population with the different combinations of, or the number of conditions that they have, which is the chronic conditions that they have. And the issue in primary care in Singapore, that the whole project, and this is a project that was funded by the Singapore Ministry of Health through a competitive funding mechanism. And I think we got a grant about 3.5 years ago. So the project is basically coming to an end. And the good thing about it is that we did a presentation. So I went back to Singapore, I think in August, and then we did a presentation to the ministry about the final project. And then they are now going to engage us to do extra stuff using the model to do some policy analysis for some new initiatives that is coming up. But if you look at the Singapore landscape for the primary care, what is really happening is that there's this issue about the current primary care. It's not the low cost of care for many chronic conditions in Singapore. So most attention is on the specialty care or the acute care services. Primary care is seen as a weak link, and then there's some inefficiencies in terms of mismatch of services. So there are specialists providing primary care, and then primary care doctors basically referring people to go to the specialists to receive care. So that has been a problem, and they want to address that. So basically, as a result of these issues about what is really going on, they are observing some high bed occupancy rate in the acute care services. And then the specialists are overburdened because they are providing basically primary care plus specialty care. And then most of the people, when they have some issues, they end up in the ED. So we have more people showing up in the ED, and a waiting list for admissions in the hospitals and also in other places are going up. So as a result, there was some initiatives that was put in place basically to try to address some of these things, which I'm not going to go detail into it, but there's been some attempt to really try to address some of the issues that is basically happening in Singapore with the community health centers basically providing services for GPs. And GPs in Singapore are basically individuals who have their own place with a nurse or a secretary in the building, basically providing services. So they don't have a lot of service, they don't have a lot of things. It's basically consultancy services and providing some medication support. So they don't have tools to really do diagnostics and stuff. And the community health centers were basically set up to support a group of GPs to provide some common services that will make the GPs more attractive compared to the polyclinics that have a lot more services that they can provide. And they have either what you call the family medicine and then the primary care network, which is a new initiative that is going on there. So if you look at the primary care, the landscape, basically for primary care, 80% of the primary care capacity is with the GPs, which are private. So the private sector controls the primary care landscape. The public sector has only 20%. And then if you go to the secondary or tertiary care, it is the opposite. 80% of the hospitals in Singapore are owned by the government, and 20% is private. So if you look at the primary care, the engagement of the private GPs is extremely important in providing care for the population. So what we wanted to do for this project was to explore the impact of enhanced primary care on the quadruple aim of healthcare. And the quadruple aim of healthcare basically is to focus on population health, cost, satisfaction of patients, and that of the providers. So this is basically what the project was basically trying to achieve, is that if we are able to enhance primary care, and what is enhanced primary care, I'm going to define that quick in the next slide. But if we're able to enhance the primary care so that they can provide much more comprehensive services for individuals with chronic conditions, how is that going to impact on this quadruple aim outcomes, which is population health? How is it going to impact on cost and satisfaction of providers and also patients? So what is an enhanced primary care? Enhanced primary care here is defined as a model of care that promotes optimal health service performance. And then if you look at the definition from from a recent publications coming in, enhanced primary care is the provision of what they call whole person, integrated, accessible, and equitable health care by interprofessional teams that are accountable for addressing the majority of individuals' needs. So it's basically a care system where the primary care provider is responsible for the needs of the patient. So they're not focusing on diseases, but they are focusing on trying to help that individual to stay healthy or to address their current conditions. And their job is to make sure that people get the care they need and they connect them to services that are not available within the primary care services. And they are responsible for ensuring that people are getting the care that they need. So what is the foundational theory for this project that we're trying to do? So one, we said that we provide services in order to maintain health and to improve poor health and to avoid worsening. So in healthcare, our goal is that we provide services to maintain people's health, to improve poor health, or to avoid people getting worse in terms of their health condition. The extent that these services produces this outcome, then the services are providing what we call needs. So these services, if they are meeting specific, if they are able to achieve this outcome, then that is what we consider as needs. These are the needs that individuals have, and the services are basically trying to meet needs of individuals. So a well-functioning health system identifies needs and assures that they are met. So if the health system is really well-functioning, what they're supposed to do is identify needs and meet those needs. And that needs are supposed to maintain health, improve poor health, or avoid worsening health. And what we are saying is that the point number 3, which is identification and meeting of needs, is the role of the primary care. So primary care is supposed to identify needs and meet those needs. And meeting needs doesn't mean that the primary care doctor is supposed to do everything, but it's supposed to coordinate and connect individuals to services so that they'll be able to meet those needs or the health needs that they have. So enhanced primary care, we are saying that does this job really well. So a normal primary care will do a good job, but an enhanced primary care will do much better job compared to a normal primary care. So what are the arguments here? The argument here is that when you look at primary care, there's the Starfield 4C, which is a very famous instrument that is used to assess what a primary care is. So normally the Starfield 4Cs are it's kind of an instrument that allows us to assess 4 main important C's, which is the first contact, the capacity, the continuity, and coordination of care. So first contact is basically saying that can people go to these healthcare services at any point in time and be able to be seen? And the capacity is, can the services provide a range of services to meet the needs of the individuals? And a continuum basically focuses on the ability for the healthcare services to provide services or needs of the individuals across their continuum of time and care needs. And then coordination is basically helping to coordinate care across different centers and across different needs of the patients. So the ability of an entity to meet the needs depend on the degree to which they're able to fulfill the 4C. So what we are saying is that if a healthcare system or primary care have a high contact, they have a high capacity or capability, they have a high continuum of care, and they have high coordination skills, they will be able to fulfill the needs of those individuals much more compared to a health system or a primary care system with a very low 4C score. So what we did here, the key issues that we wanted to focus on is how do we address this in a modeling framework? Are we going to focus on diseases or are we going to focus on something else? So what we wanted to do as a research team was to move from disease specific and focus on what we call the whole person. And then I'm going to explain what that is. And then we were also trying to understand that in Singapore, people normally shop for services. So the question is, if we build an enhanced primary care, will people show up? And if they show up, will they stay for the care? So we wanted to get a sense of how are we going to assess the attractiveness or the the preferences of individuals in terms of using those services, and then also for the doctors, their willingness to work in services that in clinics that provide such services. And then what is the impact of this enhanced primary care on transition across different health states, and then basically across different health services used. So this is what approach that we use. So we use basically what you call the Bridges to Health framework. This is a paper that was published some years back that focuses on trying to look at how population health not in terms of diseases, but in terms of health state. And this health state is based on needs. So it's basically focused on needs-based health. And here we looked at 5 different health states that was used for this project. So we have people in health state 1 who are healthy. Health state 2 is chronic condition but symptomatic. And then health state 3, we have chronic conditions, stable but moderately or seriously symptomatic. And we have long course of decline and we have limited reserve. So basically, we have an algorithm that put the population of Singapore, and we have data set from the Ministry of Health that covers mostly, not everybody, but most of the population in Singapore. So we're able to put them into each of these health states that we came up with. And they have the description of each of the health states and basically how the steps that we went through, in providing that using the data set that was available for us. So this is basically the science data set, which was a study that we have in the department in Singapore that I used to work. And then we also have the Ministry of Health data set that include death registry that we were able to leverage on for this. So this is the algorithm, which I'm not going to really go through. This is the algorithm that we use to classify individuals into different health states. So we have a clear algorithm that we go through. So we put individuals in different health states. So this is for health state 1, 2, this is a 3. And then we have for health state 4 and 5. Now, so what we are saying is that individuals move across each of these health states every year, or can be different every year. Proportion of individuals move across each of these health states. Now, the assumption here is that if you are receiving health services from an enhanced primary care, and what is an enhanced primary care? Enhanced primary care is a primary care with all the 4 C's at the very highest level. So you can have a high contact, high continuity, they have high capacity to provide care and high coordination. So what we are saying is that if you are in the usual care compared to if you are in an enhanced primary care, the probability of moving from their current health state to any of the worst health state is different for an enhanced primary care individual compared to somebody who's receiving care from usual care. So this is basically looking at how people move across each of these health states every year. Now, this is a very simple, this is the distribution of the population across different health states by age that we had. I'm not going to go through this, but you can see that if you look at the younger age group, most of them were healthy. We have a few of them in health state 2, 3, and then most of them are not in the health state 4. And then you can see as the population gets older, the distribution changes. So you can see that those who are at 60, only 26% of them were healthy, 16 were in health state 2, and then most of them were in health state 4. So the distribution is different for different health states. Now, they have a probability, what we call probability transition rate that we use to basically estimate that, to look at a population model and how people are moving across different health states. I think because of our time, I'm not going to go in there to look at the probabilities, but I can show you later when that becomes important. So if you build, would they come? Basically, the question is that, do we know the preferences of individuals? Are they willing to go to the enhanced primary care? And if they are willing, what are the characteristics of the enhanced primary care? Or what characteristics should it have to make it more attractive for them? So we did a preference study, we did a DCE experiment, basically focusing on providers and also the patient to really understand what are the things they look at in choosing a primary care. And also for the providers or the doctors, what are the things they look at in choosing a place that they want to work for primary care, and how that will impact on the preferences of patients and the preferences of providers in participating in this new primary care that the government is thinking about. So these are some of the attributes that we use for the DCE. So we have this is a DCE for the patient. So basically, they are looking at approaches to care seen by the same doctor or different doctors. And in Singapore, if you go to the public primary care with polyclinics, you have no choice than to be seen by any doctor who is available. So you can't guarantee that you're going to be seen by the same person. In private doctors, normally it's only one person, so you often see the same individual. Then the ability of the doctor to manage different conditions, services in the clinic, and access to medical records and out-of-pocket costs. So these were some of the attributes that came out from the DCs that we use basically based on different iterations of meetings and then the prototypes that we use for the DCE to be able to get the preferences of the patient and there are different levels. And this is also the attribute that we use for the providers. So the operating hours, services available, continuity of patient, typical patient load, hours of administrative work, professional development, and income per month. So these were some of the attributes that were very important for the providers that were also used to basically to determine or to estimate the preferences that the patient, what do you call it, or the providers were looking at. So these are some of the simple, some quick results from the, what you call, distributions from the DCE. This is for the patient. So we looked at it. If you look at the attribute that we considered, cost was basically the biggest one, followed by services available for the patient. And we can go. We already submitted a paper, the DCE paper, I think was last week. So hopefully, if we get published, you will see it and you'll be able to get more information on that. And this is basically for the differences for different user groups with different preferences. And then what happens is that for the patient, we came up with 3 different groups, which I think was very important. So the group 1, the group 1 prefers current clinics than other clinics. And then group 3 prefers their other clinics to their own clinics. And then group 3, they are very indifferent. They don't care whatever clinic you give them, they will go. And then cost was more important for people in class 1 compared to people in class 2. So there are different classes within the patient groups, and then these classes have different preferences. And we looked at all this, and these were all part of the input that went into the modeling to be able to help us get a sense of individual groups and their preferences and how that will impact on where they end up receiving services. So for the providers also, we look at the opening hours was one of the biggest important thing, and then patient load, and then followed by income were the things that they cared about. And then we also have different classes within the providers, and they have different preferences based on the class that they belong to. So the last one was basically to look at the impact of the enhanced primary care on transition and then health services use. So we did a Delphi study with some doctors who are GP and polyclinic doctors. And then what we did was basically to understand the attributes of the current primary care compared to a hypothetical enhanced primary care, which we define clearly the characteristics and how it's going to look like. And then we look at different variations of that. So this is basically the result of the attribute. And if you look at the attribute for comprehensiveness based on the PCAT tool, which is the primary care assessment tool based on the Stafford's 4C, the comprehensiveness is divided into 2, and then what do you call the coordination is also divided into 2. So we have about 7 attributes compared to the 4 that I showed you. And this is how they distribute across. And you can easily see that enhanced primary care often have much higher attributes compared to the what you call the usual primary care, which is what you call the typical primary care compared to the enhanced primary care. And if you look at total score for the polyclinics, if you look at the primary care, for the primary care, the current primary care, which is the private GPs, have a higher score, a little bit higher score, 19.09 compared to the polyclinics. And if you look at the enhanced GPs and an enhanced polyclinic, the enhanced GPs are going to have much higher score compared to the enhanced polyclinic. And then we have the details of each of the attributes, which also we are working on a publication on this, which I think probably you get a chance to take a look at that. And then what was very important for us is to get some estimate from the expert in terms of how they see the impact of the enhanced primary care on modifying the transition across different health states. And we are focusing on transition to the worst health state for each of the health states. It is important because each health state is different. And as a result, we're expecting them to come up with different rates in terms of the probability of modifying the way people move across the different health states, how an enhanced primary care will modify that. So you look at the first one here, we look at if somebody is the typical polyclinic and they move to an enhanced polyclinic, how would their transition rate be modified if they are in the health state 1? This is how it will modify. If they are in health state 2, this is the relative reduction that we expect them to have. So they're going to have about about 14% reduction to probability of moving to the worst health state. And you can look at that. And if you are from typical polyclinic and you move to an enhanced GP, how would that move? So this is individuals based on the health state you belong to. So we were able to get some estimate, and we went through different rounds come up with this, and we have some some sensitivity analysis bound around each of these estimates that we use to basically to run the model. So these are some of the estimates that went into the model to look at the current way people are moving across different health states based on the way health services is provided now, and then how that will change if we implement an enhanced primary care compared to the current observed transition rate across different health states. And this is the same approach for health services use. So we considered hospitalization as inpatient care, primary care, and a specialist care. And we are looking at how an enhanced primary care will modify the use of these services. So if you look at the first one, if you're in a typical polyclinic and you move to an enhanced primary care, how would your hospitalization or ED services change? How would your primary care service use change? We expect people to use more primary care, and they're going to use less of admissions and also ED. They're going to use more of, they're going to use less of the specialist outpatient services. So basically, we are looking at individuals across different health states and how their health service use will change based on the implementation of enhanced primary care compared to the observed use of these services that is estimated from data that is available in Singapore. So as I said, we build a model. The model is basically in between, and then we look at data from the Delphi studies, which is basically the impact of enhanced primary care on how people move across different health state and use services. We are looking at the numbers from the EPC studies, from the prevalences, and also from the transition rate, and then from the discrete choice experiment, all goes into the model, and then we are able to produce this output with the population health distributions and other stuff, just of cost and satisfaction from the model. So what I'm going to do is just to give you a quick demonstration of the model in Vincent. I'm not going to spend too much time because I don't think we have a lot. So I'm going to show you some few views, and after that, I'll just move on. So this is the main view for the model. And this is basically trying to look at how people move across different health states. And if you remember what I showed you, we had 5 health states. So you have people who are healthy, people who have chronic asymptomatic, there are people with chronic stable, long course of decline, and we have limited reserve. And within each of this model, we have people by age, we have them by gender, we have them by primary care service use, so that they are using the current primary care or they are using the enhanced primary care. And we also have an idea of if they have complicating features. And that is very important, especially for the health state, the end state health state, because these are individuals with long-term care needs, and they have issues with other services. And then when those services are not met, it impacts on how they move across different health states. So here we are looking at how people are moving across from healthy to chronic, asymptomatic, or all the possible transitions that are available. Remember, we didn't allow people to move from chronic to healthy. So if you are in healthy and you move to any of these states, you can't come back to healthy. But people can bounce around different health states, and not all health states were possible for people to move across. And then we will be able to get a sense of how people are moving across different health states based on their age, based on their health state, based on their gender, and also if they have using the enhanced primary care or not using enhanced primary care. And the rate that people are moving is modified by the relative reduction in transition rate, which is based on the Delphi study from the expert, as I was telling you. And what that says is that we have a clear idea of how many individuals, what proportion of the population across different health states are using specific services, either they are using enhanced primary care or not using enhanced primary care, and what proportion of them are receiving the services that they need. And as a result, how is that going to modify the transition across different health states based on the estimate from the expert? So that goes into the modification of the different health states that modify the transition probabilities that we get. The transition probabilities are basically the probability that we got from the estimate, which I said I didn't show you, but I will show you by each. So here we have female by their age, and then they have no complication, and then they have no primary care. Basically, they are not using any primary care, and we have different levels. We have so many of them going in there. So this model is very data intensive, a lot of data going in there. So basically, what this view does is that it helps us to get a sense of how the population is moving across over time, and how the implementation of enhanced primary care and an uptake of enhanced primary care will change where people receive services. And as a result, how that's going to modify the observed transition across different health states, and then that will change the population distribution. And then we have different health states. We have other health states. This is basically calculating the QALYs. So we have basically different health states and the QALYs that was used to estimate the QALYs that we have. And then we have here, this is basically the ones that are using the primary care, the PCAT that I showed you. So first contact, continuity, and other stuff, and then how that contribute to the PCAT score, and how that modifies the transition that goes into what do you call it, the model that I showed you previously. And then we have other here, look at it, this is a model that distributes the population to different health state, different services every year. And then that will help us to look at how many individuals are in each of the services, and that will impact on other stuff. And then we have a model that estimates the use of services. So here we are basically estimating the primary care service use, how people use services, and we have data from the current use and how enhanced primary care will modify where people seek care across different different health states. And the same thing this is for primary care, this is for specialist outpatient. We have one for the ED, and we have one for hospitalization. And then we have also for cost. Basically, we have how much it costs to go to each of the services, and then how the enhanced primary care is going to modify that based on the cost distribution that we have. So we have cost for specialist outpatient, we have cost for the total for the ED, and we have cost for hospitalization. And this is basically looking at the workforce. We didn't want to build a model and assume that all the workforce will be available. So what do we ask? Sorry, this is the long-term care, not the workforce. So this is basically trying to get a sense of how many individuals in Singapore with have long-term care needs, how many are at home not receiving care, how many are at home receiving services in the community, and how many of them are in the nursing home. So we look at the demand-supply ratio and how that modifies the way people move across different health states, especially among the population with long-term care needs, which I think is very important for the policymakers. And then this is where we use the DCE attribute. So you can see all the attributes for the DCE. And then basically we have different levels, and then how that comes into the estimation of attractiveness that it goes into where people are distributed every year into different health states. So this is the attractiveness of individuals, patients going to primary care, and this is enhanced primary care. And we have the same thing this is for the enhanced primary care. The first one was this is for GP, and this is for polyclinic. And then this is for enhanced GP and enhanced polyclinic. And we have the same thing for the providers. This is for the GP and polyclinic for the providers. You have the enhanced GP and enhanced polyclinic for providers. So we use the attributes, and we have the different levels, and that we use all this input to look at the preferences that goes into the estimation of how people end up. And we have, I think this is the workforce, looking at the supply of workforce and how many GPs we have available. And we have enhanced primary care, how the demand will change, and then how that is going to impact on the demand that we need in terms of training. And also in Singapore, because it's a very small country, they often tend to bring in people from other countries to come and practice in Singapore. So how many foreign people needs to come if you're going to implement this, enhanced GP, that requires a lot more GPs within the healthcare system, or how we can shift some of the doctors from the different places so that we'll be able to get the demand, so that the supply that we need to be able to meet the demand. And we have other stuff that looks at how to the roll-up of basically building up the enhanced primary care over time, and then how we can develop capacity for them to be able to more efficient to move up into the system. So there's a lot of different model pieces that comes in here. And then the last part, I think, is how you want to look at the impact of this on GDP. So what we did here is that we look at different health states, and we look at what proportion of individuals across different health states are working, and then by age. So as a result, what we are saying is that if we implement enhanced primary care and we shift the distribution of the population, the more healthier individuals we have, and the based on the proportion of individuals who are working, and then given the productivity of the individuals based on the Singapore GDP, we're able to see how this will impact on the distribution of the what they call the GDP over time. And here we are not making an assumption about productivity or anything. And we are saying that the change of distribution of the population in terms of which health state they belong to, and the probability of working based on the health state you belong to will determine how the GDP will change. So if I go back to the slides, just to end with the results quickly, we ran some simple simulation scenarios where we look at the base case scenario and a complex, which basically we assume that all those who are complex, and complex is 3, 4, 5 health state, are put in enhanced primary care. Another option is that we put everybody in enhanced primary care. And the last option is that we put everybody in enhanced primary care. And then we also convince those who are not primary care users to become primary care users. And we see how this is going to change the results. So this is a base case scenario, the distribution of the population across different health states that we are expecting by 2060. And then if you go to this, which is basically the focus, they want to know more about the elderly. So this is the distribution of the elderly population by health state. This is still the base case scenario. And then we looked at the how the relative change in the distribution of the individuals in the different health states by compared to the year 2020. And we see that some of the health states are going to have a significant increase. Of course, the only healthy ones are the ones reducing, by all of the other health states are going to increase. And we have the distribution by different age groups. And we looked at how the age distribution of the individuals in the complex health state, complex is health state 3, 4, and 5, how that is going to change. So you can see that by 2020, the distribution is very different in terms of the ages compared to 2024 and 2060. So we see a significant shift. And then we see that the number of people in the complex health state is going to increase from 40% to about 60%. This is among only the elderly population. And then we looked at comparing different interventions. So here is the population. And this is which was quite interesting, that without doing anything, just implementing the enhanced primary care, the population of Singapore is going to change. And that is because we are going to, the enhanced primary care is going to have impact on mortalities across different health states. As a result, the population itself is going to change. So if we put all the population in enhanced primary care, and based on the assumption of the expert that enhanced primary care will have reductions in the way people move to different health states, and different health state is associated with different population probability of dying, then you can see that there's going to be a significant increase in the population because we're going to have people living much longer compared to what it would have been. And then we looked at different health states, and we have the distribution of the population across different health states by different interventions. So you can see that most of the different health states are changing. I don't want to spend a lot of time on this. And then we look at the QALYs, and here we see that we will see some significant improvement in the QALYs. These are QALYs per capita for the population. As putting all the population together, you can see that we're going to see some improvement in QALYs. And also look at the complex population in the complex health state for the whole population on your left, and then the elder population on your right. We see that you're going to see some significant changes. And here, the enhanced primary care, where we put everybody in enhanced primary care, and we also convince that non-primary care users to become primary care users. We're going to see a significant increase in the number of individuals with complex conditions. And that is very counterintuitive. And the reason being that if we provide enhanced primary care, you're going to keep more people alive. And as people live longer and the probability of dying goes down, you're going to have more people with complex health care, with complex, what do you call it, in the complex health state, which is health state 3, 4, 5. So that proportion is going to increase. But of course, we're going to have an offset in terms of the productivity if they are productive and they'll be able to produce to offset some of the cost that is associated with being in that health state. And here we have the healthcare service use, which we accounted for primary care, for ED, specialty care, and also for hospitalization. And then also the same thing for expenditure, which I won't spend a lot of time. And we look at the total expenditure for healthcare compared to the GDP. So you can see that if we do the all enhanced plus everybody becoming a primary care user, the healthcare cost is going to go up significantly. However, we're going to see also an increase in the GDP based on the distribution change in the population, and then attaching the distribution change by the proportion of individuals in each health state that are working. We are going to see an improvement in the GDP. And then there's some insight in terms of what's the value of this and how this is going to help in helping the policymakers in looking at some interventions that they are rolling out currently in Singapore. So I think I'm going to stop here, and then hopefully there's time for questions. Yes.
Thank you very much, John. Lots of information.
Yes. I'm sorry about that.
No, actually, that's very good. A lot of work. Questions?
Yes, Gary.
Hi, John. Thanks very much for that presentation. It was a tremendous piece of work that you did. Really very impressed. You went past the graph of total cost very quickly. I'm wondering whether there were significant savings achieved, especially in hospital care, given the shift in the population that enhanced primary care were able to produce, and whether there was the possibility of total system savings which could be reinvested in subsidizing enhanced primary care, especially if people identified cost as a significant attribute in which model they would choose.
Yeah, thank you very much. So let's spend some time on the cost. So if you look at the cost, if you look at all the options, the base case is the blue line. So for all the options, the scenario that we considered for primary care, we are going to see increase in primary care costs. Why is that? Because we expect enhanced primary care to help people to have more access to primary care. So they're going to use primary care more. And as a result, the cost of primary care services is going to go up. However, we see trade-offs. So if you look at the hospitalization, the base case is the top one, the blue one, and all the scenarios are going to have a reduction in cost in hospitalization. So you're going to see reduction in hospitalization costs. The same thing with the specialty services use. We're going to see reduction in that. And then also for the ED services, you're going to see a reduction in cost. So the increase in cost is mainly from the primary care. And the primary care cost is significantly going to increase because if you look at the assumptions that the stakeholders gave us from that Delphi study, if you compare all the use of services in all health states, they expect primary care use to increase if we implement enhanced primary care, because we're going to bring more people into the system and we're going to make sure that we implement programs in place that allows them to provide them more services. So primary care service cost is going to go up. However, other costs is going to go down. But the total cost that we come up with, which is this one. If you look at the base case scenario, this is the blue line cost. And then if you look at the intervention, if we put only complex patients into enhanced primary care, we will have cost savings. This is the red line. If we put all individuals in Singapore into enhanced primary care, we're going to have a savings, which is the green line. However, this last one, we are bringing in people who are not primary care users, who are not becoming primary care users. And in Singapore, that's what they are trying to do now. They are trying to make sure that every Singaporean now have a primary care provider. And they're supposed to do some basic checks up every year. So what you are saying is that if we bring in all the populations who are not seeing primary care to become primary care users, that is where we see the cost jumping up. But you're absolutely right. We see cost savings if we are considering focusing on complex or all individuals who are now primary care users going to the enhanced primary care. We will see a reduction in cost, which is the red and green. But when we bring everybody into the system, which is people who are not showing up now becoming part of the system, that is where we see the cost going up. So there's definitely going to be cost savings, yes.
Thank you. Well, I'll ask one more. Were you projecting a change in capacity for primary care, or just a shift in the models through which primary care was provided?
The capacity will change significantly. So especially for if the assumption is that enhanced primary care will require the visit length will be longer. So if you go to now in Singapore, if you go and see a normal GP, you will spend between 5 to 10 minutes per visit. Now, in enhanced primary care, the assumption is that people are going to spend much longer time because we want to make sure that we have a more conversation to understand people's needs so that we can address them. So that capacity is going to change because they're going to the workload is going to reduce. So they're going to see less patients compared to what they are seeing now. As a result, they need more manpower to be able to address the needs. That is why we build the we built the what we call the workforce model part to be able to ensure that we have some handle over what is the workforce requirement, so that we don't end up assuming that everybody who needs primary care will get primary care, right? So here we have the MD student, we have those who are house officers, we have residency, specialty medical officers, and then general practitioners and family medicine. These are the primary care users. So we have scenarios where we can pull people from here and here who will come and join, or we can hire people from outside, which is foreign GPs coming in to the capacity. So the demand for primary care is going to go down, it's going to go up significantly, and we will need more manpower. And then the question will be, either you're going to use these guys who are in the hospitals helping out to come into the system, or you're going to hire from foreign to be able to supplement the what we call the capacity to be able to provide the needed services. So that is accounted for in the model.
In looking at the workforce, do you look at all at the ability to use what in the U.S. we call mid-level practitioners, nurse practitioners, and physician assistants?
Yeah, so we had that discussion in Singapore, and then the discussion the issue that came up was that we should now, for now, we should focus on the doctors. But absolutely, that's a possibility that we can use mid-level staff to provide some of the services that the GPs are doing, which I think is very practical and makes a lot of sense. But for this project, the focus was on only doctors.
Because that might significantly reduce the cost of the enhanced primary care if you had a different mix. Yeah,
absolutely. You're absolutely right. Yeah. Is there a question? There was a question.
Yeah, the question is about some of the counterintuitive results that made your stakeholders think. Did you find aha moments or things that were?
So I think
puzzling?
Yeah. So there were a lot of discussions on different pieces. If you look at the work, we had there were about 4 different pieces. We have literature review, looking at the evidence and trying to figure out what are some of the things that we're going to use in the model. We have the DCE part, and we have the EPC study that focus on the estimation of cost and estimation of transition probabilities across different health states. So if we look at the DCE part, there was a lot of interesting findings that from the DCE, which I think is not really what I'm presenting. But in the model part, yes, there were issues where people were were a bit not comfortable with. And that is exactly what Gary was pointing at. Because of the cost. The cost was something that they were surprised that they are likely to basically end up spending more money. And then the question was, what is happening? And if you look at the table that I showed you here, some of the interventions, what you're going to see is that let me show you one of this here, the health state. So look at this, some of these interventions, you're going to end up increasing the number of people with their chronic conditions. And why is that? Because if you implement a very good health services, enhanced primary care, and then remember, this model is heavily dependent on the assumptions of the impact of enhanced primary care on transitions and costs on health service use. That was estimated by the expert. Right, that is a very important piece of this model. So what we are saying that if that reduction that they gave us is true, what we are saying is that by implementing enhanced primary care, some of the individuals who are in the health state are going to live longer. And when they live longer, right, the population in that stock is going to go up. And when it goes up, you're going to spend more money on them. And remember, as I showed you in the beginning, that the population of the country basically changes just by implementing this this primary care. We see the change in population, and this is not because there's foreigners coming in. It's because of the interventions that we are implementing and the assumption that we have in the model. So what it means is that we're going to have a lot more people living with complex conditions, which has a cost implications. And people were expecting the opposite, that if we implement enhanced primary care, we're going to have less people with complications. But these people already have the complications, and we're going to keep them alive for much longer. As a result, you're going to spend more money on them, and it's going to cost more money. It's going to cost. However, the counter argument is that the issue is if these people are productive, because if we keep them alive and they are healthy enough to be productive, then you can get some benefit from the GDP which can be an offset for the cost that we want to incur on them. So there were some insights. Some of this is one of the things that people were really surprised that why is it that we're going to have a lot more people living with complex conditions? And the reason is that we're going to keep them alive for much longer because our intervention is going to work. And as a result, we're going to spend more money on them.
Very good. We have time probably for one more question, one or two.
There's a question last one. Did you model any wider determinant of health? Okay. Yeah, so we did not look at social determinant of health has not been, it was not something that we looked at here. And I did present this model to the Metro Health in Cleveland a month ago. And this is the first thing that they came up with, that they would really like to do this model and focus on social determinant of health, because that is something that is of significant interest, what do you call it, in the US here. So I think it's something that I'm considering, and there's a possibility for me to look at that. So if you have interest in it and you want to work on this, we can have a conversation and see how we can take that and then use this model to do that. But yes, I have interest in applying social determinant of health and in what do you call it, and include them in this model, but we didn't account for that in the Singapore model. Yeah, it was not accounted for.
Other questions?
Okay, yeah, she said that they are doing something similar, looking at determinant of health for asthma and respiratory conditions in the UK. Okay, yeah, that would be, let's have a conversation. And if maybe we can have some collaboration, that would be nice.
I think in an enhanced primary care model, you can probably assume some impact on social determinants of health, asking patients questions about things like their housing and how that might affect asthma or something like that. So there might even be benefits of enhanced primary care beyond what you've already modeled as you get into other social determinants.
Yes, yes, and I think that is one thing I'm trying to figure out, is that when the hospitals are trying to understand what are social determinants of health for the patient that they are seeing, the question is that, are they connecting them to services that will help them to address some of these issues? And then can we track to see how it impacts on their, what do you call it, the way they move across different health states? Because it's obviously that social issues are extremely important in terms of health. And then if it's not addressed, it basically have significant impact on the effectiveness of the intervention that is being implemented. So I think you're absolutely right on that. And Vanessa, it's something that we can have a conversation and see if we can work on something with the work you are doing in the UK.
Okay. Any other question, comment? Thank you, John. This was a very interesting presentation, which was obviously showing like lots of work. I don't know how long you have been working on this project, but it was a
it was this is a 3-year effort. 3 years.
Effort,
yes.
Obviously.
Yes.
Yeah, great. Well, thank you for sharing the work. I'm sure that Wayne will communicate about our next meetings. I don't have the schedule, but thank you all for attending today's seminar.
Thank you guys for showing up.
Bye.
Bye.